At ESMO 2021, I've been invited to take part in a debate with Michael van der Heijden on a really important topic, which is adjuvant therapy with immune checkpoint inhibitors in kidney and bladder cancer. I've been asked to take the pro side of the debate, but today I'll try and give as balanced approach as I can. In the debate itself, I might be a bit more bullish than this, and I hope Michael will take the other side and argue against these data, which are controversial. I think it's widely accepted in both of these cancers that we need to see survival advantages in the adjuvant setting. Let me explain a little bit why that's the case. Essentially, what we're trying to do is make patients live longer or feel better. In the metastatic space, delaying progression-free survival can be beneficial in many different ways and may or may not translate to overall survival. But in the adjuvant setting, many patients will not relapse. Those patients will be exposed to potentially toxic drugs. And therefore, if all we're doing is delaying the time for the cancer to come back, it's not clear that that's of benefit. Now, that's an area of debate, and that will be part of what we will talk about. But I think most people feel that in both cancers, overall survival is the primary goal. One of the challenges is it can take many years to get overall survival signals. So if you have impressive adjuvant data with PFS signals, great PFS signals, with perhaps early overall survival signals, you might say, well, we should give the patients the benefit of the doubt until we see that overall survival. Now, if that survival doesn't come in, you might say, we should stop that. But as it currently stands in kidney cancer, we have the KEYNOTE-564 study. The PFS hazard ratio is statistically significant in 1,000 patients. It reduces the risk of relapse by about 30%, 32%. And that's statistically significant. There's also an early survival signal. Now, there have been relatively few events. The reduction in the risk of death is about 40%, but I don't think you should interpret that. It's only based off of about 50 events in a 1,000-patient trial, but the curves do go apart. And that going part of the curve, that, in my opinion, will be attractive for patients because they'll sit there and say, well, I can't wait 3 or 4 years till these survival signals come out. And if there is a significant delay in survival, and there is a link between delay in survival and overall survival, and the overall survival is going in the right direction, I'd like to have this. Remember, it's for intermediate and high-risk patients, and that's really important. It's also important to recognise there's some toxicity associated with the drug. And one of the things which I'm going to talk about is I think patients need to be really well informed. Clearly, it's possible if you only say the upside of the argument, patients are likely to say they'd like it. And if you only say the downside of the argument, we don't know whom it benefits, you're going to get toxicity, patients will probably walk away from it. So I think it's going to be a really important, informed decision with patients. I don't know how the debate will go, we haven't had it yet. The second group in bladder cancer is actually more complicated, it's more nuanced, and the reason why that's the case is there is a positive trial for disease-free survival for nivolumab, for adjuvant nivolumab post-cystectomy. That has no survival signal yet. There's a 30% reduction in the risk of progression. But without that survival signal, we're really in the dark as to whether or not those curves are going apart or go apart in the future. So it requires a little bit more faith around the link between disease-free survival and overall survival. There's data on disease-free, metastatic-free survival that's been published in the New England Journal of Medicine as well. And that may help people make decisions positively. However, without survival, it's complicated, and the reason it's complicated is we have an atezolizumab study versus best supportive care, which didn't hit disease-free survival and has read out for overall survival and is not significant. Now, the positive people in the room will say nivolumab's a different drug, the trial's got a different design, it's going in the right direction, it did hit DFS. The negative people in the room will say, well, we've got a negative survival trial. In bladder cancer, there are more similarities than differences between nivolumab and atezolizumab. Under those circumstances, we probably shouldn't jump all over this until we're more confident in the knowledge that we're putting some patients in harm's way with long-term immune-related side effects.